Okay, Assalamu alaikum, everybody, and good evening to all our friends and colleagues who are joining this conference from Bangladesh. Today, we are about to discuss an uniquely challenging and fascinating topic, which is diagnosis and management of cardiogenic shock in the resource-limited settings, such as in Bangladesh. We may touch upon some of the technological advancement in this field without going into the details, too much details, for the very reason, as you can see, the name of our topic. I'm Dr. Habibur Rahman. I'm formally trained in anesthesiology, internal medicine, pulmonary, and critical care medicine. I'll be moderating this session, inshallah. But before I proceed, on behalf of PHA, I want to express my heartfelt thanks to Incepta Pharmaceuticals and United Health for their unceasing support for this academic educational platform. We are very fortunate today to have with us an esteemed group of panelists, including, and I'm going to name them one by one, Dr. Timir, who is a professor of medicine and director of Cardiology Fellowship Program at the University of Tennessee Health Science Center. Dr. Shiraji Munira, who is an associate professor of medicine and cardiology, and recently took the responsibility as chief of cardiology in the Lincoln Medical Center. Dr. Tasbirul Islam, I don't want to introduce him. He is the founding chairman and his main force, energy, and spirit to run this organization. He's an associate professor of medicine, pulmonary and critical care in Rosalind Franklin University of Medicine and Science in Indiana University. Dr. Jafar Iqbal, I don't see him yet, but he's part of the panelist. He's a senior consultant in critical care medicine in Evercare Hospital. Dr. Abdul Momen, who is an associate professor of medicine and cardiology in NICVD. Dr. Motiul Islam, who is a consultant and coordinator of critical care medicine at Asghar Ali Hospital. And Dr. Raziuddin Ahmed, who is an associate consultant, critical care and internal medicine at Square Hospital Limited, Bangladesh. Dr. Alamin, who is an assistant professor in Bangladesh Medical University. And finally, our main speakers today, Dr. Ahmad Morshed, who is an interventional cardiologist at Arnot, Ogden Medical Center, Maimonides Hospital, New York. And a case will be presented by Dr. Salman Salehin. Salman is a board-certified internist, and he's a third-year cardiology fellow in the University of Texas Medical Center. With that, we'll start with a brief, approximately 10 minutes case presentation by Dr. Salman Salehin. And then Dr. Morshed, our main speaker, will present the topic over 30 minutes or so. And after that, I will request the panelists to speak, each one of them, approximately 2 to 3 minutes, commenting on the topic, briefly sharing his or her own experiences, and of course, can ask questions to the speakers, to the panelists, and of course, myself. And finally, we'll close, we'll open to questions from everybody, from all the participants. We'll end the session with a brief summary of what we learned today. So with that, now I'm requesting Salman to present his case. Salman, please.
Thank you, Dr. Rahman. I hope everyone can see my screen.
Yeah.
I just started sharing. Can everyone see my screen?
Yes, Salman.
Okay.
Nice.
Thank you. Thank you. Ji, so assalamu alaikum and a very good morning to all our faculties and our panelists here in the Central Time Zone and the Eastern Time Zone, and then a very good evening and assalamu alaikum to our faculty panelists and an audience in Bangladesh. Thank you for joining us in today's session. Before I came onto this session, I realized that there was a very bad fire in Shah Jalal International Airport this morning, and our thoughts and our prayers go out to all the families and people affected, and our prayers are with the firefighters, armed forces, everyone involved in trying to control the fire. Basically, the session today, the topic is management of cardiogenic shock in resource limited setting. This is easier said than done, especially because cardiogenic shock itself, it's a very difficult diagnosis to manage overall, and limiting resources can be even add an extra layer of challenge to that. So I'll try to make our case as interactive as possible. So any input from the audience, the panelists, trainees, and faculties both alike would be appreciated at different points of the case. So I'll go ahead and get started. As Dr. Rahman had pointed out, I'm a general cardiology fellow here at University of Texas Medical Branch. And my case today is about a STEMI patient, which was complicated by cardiogenic shock. So the case presentation, we had a 50-year-old gentleman, Mr. Rai, who past medical history of high blood pressure, not on any meds. He's actually from India on a merchant ship. He came to the Gulf of America, and at 9:30 p.m. on October 2nd, so this is a very recent case, just 2 weeks ago, he was brought in by the U.S. Coast Guard to our ER with uncontrollable chest pain, chest pressure for the last 36 hours. Yes, you heard me correct, 36 hours. Mr. Rai had been sitting on his chest pain for 36 hours because he was in a merchant ship. He didn't know what to do. Finally, he did go to the doctor on the ship, and he immediately life flighted him to our center. The initial EKG showed ST elevation in the anterolateral leads. And, this is a case where it's a very clean-cut EKG, right? There's no debate on, do we call it a STEMI? Does it meet criteria? Should I wake up the interventionalist in the middle of the night? This is not one of those cases. This is very clean-cut anterolateral all the way from V2 to AVL, lead ST elevation. And even the V2 is almost 4 millimeter ST elevation, the cutoff being only 2 millimeters. So pretty bad STEMI, and immediately STEMI was activated. We loaded the patient with 81 milligram aspirin, loaded him upstream with Brilinta 180, and heparin loading dose was given, followed by transferring him to our cath lab. Some EKG, we shot the left side first. As you can see, the left side, the circ looks good. There are a few big OMs here, very minimal disease. But the biggest elephant in the room is actually not seeing an LAD that should have been crossing the anterior wall all the way to the apex. The next shot we got was areocranial. This will be even more visible here. As you can see, there's a LAD stump. That represents the acute occlusion of the LAD. We put a wire down the circ. We put a wire down the lesion as well. It was a soft plaque, easy to cross. We crossed the LAD. We pre-dilated with a balloon. There wasn't any heavy calcium, so no atherectomy devices were needed. Like I said, it was a soft plaque. We put the wire all the way to the apex. We did IVUS, and then we put the stent in. Obviously, in our institute, we're practicing IVUS much more nowadays, almost 100% in ACS cases, especially after the recent ACS guidelines came out in 2025 that gave a 1A recommendation for using intracoronary imaging, either IVUS or OCT, in the case of left main and complex coronary lesion. So we tried to abide by that. We put a stent, 3.0 by 20 stent. We did post-DIL, and as you can see, the left LAD has finally parked up. It's a pretty big LAD, all the way wrap around, type 4 LAD, providing about a bit of contribution to the inferior wall as well. We shot the right side, nothing to write home about on the right side, no major disease, pretty good size RCA. So, the patient, we fixed the STEMI, but STEMI is only part of it. The complications arising from the STEMI is equally important to manage, sometimes even more difficult to manage. The patient had a LVEDP of 27, increased. Patient was blood pressure was on the softer side. He was a bit cool and clammy. So he was on impending shock. So for patients who are in cardiogenic shock after STEMI or impending shock or high risk of being at shock, especially someone who's been sitting on a LAD STEMI for 36 hours, we thought it would do justice to do a right heart cath in this setting. And the numbers correlated with what we thought. The left-sided filling pressures were severely elevated with a wedge of 28. Right-sided filling pressures were severely elevated at 16. PSAC is abnormal. And as expected, the cardiac output index was low as well, with the output of 4 liters, index of 2.40. Some calculated values that we obtained. The shock index, that's something very simple to do. You don't need any special devices. It's basically your heart rate divided by the systolic blood pressure. Normal should be below 1. So anytime if your heart rate is above the systolic blood pressure, that's an indication that patient is in shock. That is what we call the shock index. In our institute, we usually use PAPI, the pulmonary artery pulsatility index, to quantify RV function. The PAPI for this patient was 0.7. Normal is obviously more than 1. CVP is high, so his RV was also, he also suffered RV insult, as can be seen. The pulmonary vascular resistance was within normal limits, 1.6 Woods unit, normal below less than 3, so no precapillary component there. And systemic vascular resistance was elevated as expected for someone in cardiogenic shock. So at this point, knowing that a patient came in with the LAD STEMI, sat around for 36 hours, we did a right heart, these are the numbers, elevated bilateral filling pressures, low cardiac output. My question to the audience, the panelists, is what do you think would be the next best step in management for this patient? If anyone would like to.
Yeah,
Salman,
one thing I would do here, that cardiac power output,
Yes.
that will help. So whether it's but definitely for this particular patient, because there is no there is no inferior STEMI or no posterior STEMI, so I'm assuming that this is all left-sided, so due to LAD. So all these numbers are impending shock, as you mentioned, on early shock, because it's all a borderline, but definitely in shock because of EDP and RSI. So I would just, in our institution, I would just put Impella for this particular patients, but I would calculate the CPO just to make sure, and just give a support and then redo another right heart cath in next day and see what are the numbers, and then we can win it out.
Excellent comments. Thank you.
Salman, I have one question. That is, can you tell me the patient was in SCAI shock stage, which stage patient was in?
I mean, the assumption would be with these numbers, he would be at least C. He's gonna be hypoperfused, hypotensive. I mean, we don't know if he's gonna be D or not because we haven't acted on it. Let's say if we put a device and he's deteriorating, then he'd be SCAI D. But based on this, I'd say at least SCAI C.
Okay. So in stage C, do you routinely use circulatory support, or it's plus minus whenever needed you use it?
Right. So excellent question. So I think that's why we do the right hearts in these cases, just to guide us to see if we need a device or not. For this particular case, given that the output and index is low, wedge is high, what Dr. Paul very clearly mentioned that he would have done an Impella. Actually, I was part of the day team. That's what we thought. Doing the Impella would be the right thing. But the night team actually thought that, the shock wasn't as bad. They'd rather do a balloon pump to afterload reduce and to perfuse the coronaries. But I wholeheartedly agree with Dr. Paul that the Impella, especially after the danger shock trial, our institute has been going more towards Impella after STEMI. But in this particular case, what happened was the night team placed a balloon pump. So there was a prox LAD lesion. We did PCI of it, elevated filling pressures, moderately reduced cardiac output index. We put a balloon pump. And obviously, we didn't want to upset the cardiac intensivists on the floor. Easiest way to get them upset is not to place a VIP Swan-Ganz catheter in a patient with cardiogenic shock. So we did not want to upset them. We placed the VIP Swan. We wanted to start him on some preload reduction as well on Lasix 40 IV BID on a Lasix naive patient, and we sent him back to the floor. at 1 a.m. So the STEMI was at around 9 p.m. At 1 a.m. when the patient was in CCU, was evaluated by the CCU fellow. He was doing fine. NO times 4. Extremities were on the cooler side, but no edema. Urine output was 40 cc an hour, so not particularly satisfactory. A point to note would be this patient is Hindi speaking only. So there was a language barrier there, but thankfully the night fellow was from a gentleman from Pakistan, and the day CCU fellow was me. So again, I don't speak Hindi well, but I can understand Hindi a little bit, courtesy of all the Hindi Indian channels and Bollywood movies that we get exposed to in Bangladesh at an early age. So initial lab works came back by then. His CBC was unremarkable. TBL was elevated, some elevated AST, ALT as well, indicating hepatic congestion. Electrolytes were fine. Troponin, the first troponin was through the roof. 120 is super elevated, but the lactic was at 1.09, so within normal limits. At 5 a.m., the night CCU fellow decided to repeat the SWAN numbers. It's been 4 hours, and what he saw was the numbers were not super great. The blood pressure was soft. CVP was still elevated at 25. Wedge was still elevated at 25. Cardiac output index was actually lower than before the balloon pump, and lactic is slowly coming up. And we calculated the PAPI as well. PAPI was low as well, 0.6, indicating some form of RV insult. At this point, with someone who we've placed a balloon pump on and SWAN numbers indicating still elevated filling pressure, still reduced cardiac output and index, what would be the next step in management? My question to the respected faculty panelists.
Right. Actually, this is Dr. Morshed. So definitely we have to upscale to the Impella, as Dr. Paul said before. There's a couple of things here. So when the patient was deteriorating, even in the cath lab, there should be like a lactate should be checked, and also from the cath lab, the patient should not have transported to the floor without having SWAN in, as because definitely it's a 36 hours. The minute the patient has a reperfusion, I'm sure the ejection fraction was like 20 to 25%. And when you checked the second number, the SWAN number after 4 years, it's kind of little like a longer period, like we should have done it earlier. And if we see the numbers after 4 hours is actually from stage C to going to stage D, even on even on a balloon pump. So definitely at this point, I think I would rather go with the Impella.
Thank you so much, sir. I think that's exactly our thought process as well as part of the day team. There's someone, yes.
Salman, what did you think about IVP? I mean, was it, I think, is it your protocol you first?
No. I think our protocol is actually Impella CP, especially after the Danger Shock trial came out last year. We've been very heavy on Impella CPs after STEMI cardiogenic shock patient. But the night interventional faculty basically thought the patient was not in bad enough shock to need an Impella. Based on his numbers, he thought the extra 0.5 to 1 liter output from the balloon pump with afterload reduction with coronary perfusion from the balloon pump will be sufficient. And speaking to him the next day after, I think he also he didn't have a good night's sleep that night. He thought that maybe I should have put an Impella up front, maybe I shouldn't have done a balloon pump, but it is what it is. He had made the call at that time, and like Dr. Morshed sir mentioned, the lactic. So lactic was checked in the cath lab. It was below 1.5. So that also had a contribution in his mind, like, hey, even the lactic is fine. Maybe I can get away with the balloon pump. But our protocol is Impella, yes. So thank you. So I wholeheartedly agree with Dr. Morshed sir. This is a time where Impella upgrade should have been considered, but the night team basically wanted to sit around. They called the interventionist again. He said, try to start some low-dose levofed. Maybe the maps would be better. The numbers would be better. Lactic is still within normal limits. So he didn't want to activate cath lab at that time. That was, you can have your own opinions about it. Echo was done at 7 a.m. and this is the echo findings. Again, the LVC is completely down. Dr. Morshed sir even predicted 20 to 25%. I think it might be even lower. Bit of small pericardial effusion at the posterior end. The RV free wall is moving, but the septum is not moving. Again, another 4-chamber view. The RV free wall is moving, but the septum is completely akinetic. There's some ischemic MR. as expected there. Subcostal view showed the same thing. RV free wall is moving, septum is not. You can see the swan catheter within the RV. So, and this is one contrast image. There's a possible, there was a questionable unable to exclude thrombus scenario here, but the EF again wouldn't be more than 20%. I think the report called it 20 to 25%. Whoever was reading the echo that day was a bit generous, in my opinion. RV was reduced systolic function. TAMP-C was 1.5, but again, it's borderline low if you if you base it off the TAP-C, but the take home is the free wall was moving, so the TAP-C might actually look better than what the RV is really doing because the septum is completely down. At 8 a.m., we repeated an EKG just per protocol. Again, ST elevations persistent at V2, V3, 1A. So ST elevation is persistent. My CCU resident actually came to me with this EKG and said, oh, do we need to activate cath lab again? But I explained to him that if you compared with the post-procedure EKG, this looks about the same. Now, the ST elevations were supposed to go down after revascularization after a few hours, but this patient has an aneurysmal LV now. So the persistent ST elevations are from the aneurysmal LV. So by this time, I had come in at 8 a.m. The first thing I did was repeat SWAN numbers. The blood pressure was okay. CVP was a bit better, but wedge was still high. But the output in index just looked so bad. In fact, I doubted, like, is the SWAN numbers even accurate? Because when you look at the patient, he's doing fine. He's not having chest pain, shortness of breath. He seems to be okay. So I actually started to doubt the SWAN numbers. I got an X-ray. X-ray looks perfect position, and I calculated a FIC with the ABG and a VBG from the SWAN port. It actually correlated very well with the numbers. The lactic was still elevated, although it wasn't going up, but urine output was going down. PAPI in this one was okay, so we thought maybe the RV is okay, but I actually called my CCU attending right then and there. I said, hey, we need to possibly upgrade it, as our speakers have previously mentioned, that probably would have needed to be upgraded at 5 a.m. with those SWAN numbers. So I called the cath lab activation for upgrade to Impella CP, and we had hoped that, with the LV support, the extracardiac output would be, that's all it takes. So patient returns back from the cath lab, and about a few hours after, we decided to run the SWAN numbers again at 1 p.m., expecting it to be better, but to everyone's surprise, blood pressure again on the softer side. CVP now has gone up again. Wedge has actually gone up again. Output and index is exactly the same on the Impella as on the balloon pump. PVR was good. SVR, systemic vascular resistance, was super high. At this point of time, based on these numbers, with still bilateral elevated filling pressures, reduced cardiac output and index, with lactic being slowly going up to 1.7 now, urine output very low, PAPI of 0.6, so indicating RV insult. My question to the esteemed panelists, what would be the next step in management, or what would you do in your center?
So first of all, again, I want to reemphasize that very first time, this is OL late now. The cardiogenic shock, earlier we support is the best. So that very first time with the cardiac index of 2, anything less than 2.2 is already clear-cut shock. So you have to look at the cardiac index and output. Of course, the CVP and all these things is high because of, and also you have to think that this patient is late presentation, right? Look at this EKG now is all key waved, like V1 to V6, everything. As Dr. Morshed said that is like already EF is low. You can clinically think. So first of all, you should have done and way late, and balloon pump would not help anyway. Right now, his PAPI is less than 1.5 is a cutoff. Less than 1 is definitely right side failure now. So, and you saw the TAP-C is 1.6, 1.5. So there are some component of right ventricular failure now. So either you put the biventricular support with the Impella, because Impella is not helping much. So either ECMO, in our center, I would do the ECMO. I don't know, not every center may not have ECMO, but I would know just ECMO. What is the pH and oxygen saturation? That's two other important things that you also have to, ABG have to, will be very helpful here.
I agree with Dr.
55%.
So I think the next option, either even if we go to 5.5, but it will not help that much as because RV is going down. So there is Impella along with the VA ECMO. And also the very important thing, as like we mentioned before, we cannot sit on this type of patient for 12 to 24 hours. And we are like taking the decision way slow, and which is like a kind of dangerous thing in the cardiogenic shock.
So 100% wholeheartedly agree with both our faculties. Yeah, this is something that needed to be acted
Just
on in the
one
night
quick
before
point of
actually.
clarification, Salman. So when you found that the TAPC was 1.53 and the septum was not moving, did you feel that most of the contribution to the drop in cardiac output was coming from the right side or left side? What was
Yeah,
the
so I think
sense of
with the
understanding
case
at
the
that
whole
point?
time. Yes, sir. Good question. So that is actually a very important question. We've
And is
been
that the
focusing
reason
on the
the IABP was not as effective as you expected at the beginning, even though it was not that bad to begin with?
Exactly. So in hindsight, that is what we thought. Like Dr. Paul had initially mentioned after the first slide, it looked like LV insult, and that's what we were focused on the whole time, the LV. But we never thought to basically look at the RV because we thought it's anti-LAD. It looks that it's LAD disease. In some SWAN numbers, we were getting a PAPI that was acceptable. CVP was actually okay in the 8:30 a.m. hemodynamics. So we actually kept blaming the LV. But after this 1 p.m. hemodynamics, we realized that we were basically going up the wrong tree. We were blaming the LV so much, but it was probably the RV, which, on the echo, the free wall was moving. It didn't look that bad, but we realized, and I read about this later on, that the septum actually contributes 40 to 50% of the RV function. So if LAD is STEMI, if your septum is gone, your RV is already 50% down. So no matter how much the free wall appears to be moving, or maybe the TAPC can be falsely normal or borderline normal, your RV is probably the issue. So we at this point we realized that it was an RV issue. But again, the
TAPS
reason I
is
chose
only the annular excursion. This is not the whole function of the RV.
exactly. TAPC is only the longitudinal annular excursion focused on the lateral wall. So if the
Yeah.
free wall is moving, the
TAPC
TAPC can be falsely.
and also
So,
TAPC will not give any significant information in this type of case.
correct. So I think in these sort of cases, hemodynamics take over from echo. Obviously, hemodynamics is the way to go. But again, the
Well,
topic of our
Salman,
yes.
Salman, I was thinking that why the patient is having RV failure. Could it be the type 4 LAD can contribute in some way, the RV failure?
Very good point. Very good point. The patient, initially the angiogram, it had type 4 LAD, wraparound LAD. You could say at least 25% or more of the inferior wall being supplied by that LAD. So that was one. And obviously a long-standing 36-hour infarct with the septum now being completely akinetic, despite being revascularized, it's probably infarcted. Those are the two reasons that we thought in hindsight that it was RV was the main reason. And that's at 1 p.m. based on these numbers, our suspicion was corrected. So basically, the topic today was management of cardiogenic shock in resource limited setting. So that's why I chose this case, because it sort of taught me a lot. Next step, I know everyone mentioned the correct next steps, that RV support, ECMO, but what really we did for this patient is we started him on milrinone. Now, some people would raise their eyebrows like, hey, ischemic cardiomyopathy, do you really want to do milrinone? Our thought process was patient was revascularized. Let's give him a chance with milrinone 0.37 at a higher dose. But we notified cath lab that we'll give him an hour or two on this milrinone, checking numbers repeatedly. If doesn't work, we'll put an Impella RP or we'll activate for ECMO support. But we wanted to give him a chance on the milrinone just because, patient was asymptomatic. We thought we had at least 30 minutes, an hour to see how he does on the milrinone. And to my surprise, because I was with everyone, I thought this is waste of time. We should just activate to get the Impella RP or get the ECMO in. But to my surprise, I was sitting in front of that patient's room for these 2 hours. I couldn't move because he was the sickest patient in our CCU. We kept getting numbers, and I could see in front of my eyes the numbers improving every 5 minutes, every 10 minutes. His CVP FCP dropped from 25 to 17. His wedge dropped from 22 to 17. His lactic still borderline elevated, but his Foley catheter, the catheter bag, which was completely empty, within a matter of 2 hours, it was over 300 cc. Patient said, hey, all of a sudden I feel much better. I wasn't having symptoms, but now I feel better. And we decided to, we saw these numbers on the Impella CP and the millinone. We decided on, I'll tell you what we decided, but based on these numbers, would anyone do anything different on what, I guess we talked about the differences, but would anyone do anything different at this point of time?
It's improving, but your PAPI is still 0.5. It's pretty low, right?
Right.
As I mentioned, that less than 0.1, less than 1 is acceptable, but less than 1.5 already is in the algorithm. But it's improving. You can watch and see it's continue to improve. But three comments. I think the very first right heart cath when you saw, it was very, very high SVR2, right?
Right.
So that time, I think instead of now after the Impella, when you put the balloon pump, we should have put millinone on there too. So that will the SVR will decrease and like the contractility will increase some.
Yes, sir. 100%. I think that was the thought process. Sorry, go ahead.
And then second one is Dr. Morshed already commented again. I want to emphasize that we should have done that after given balloon pump earlier, that all these numbers like 4 hours, and to see what is improving or not instead of like way late. But you are in the right direction. You did a good job.
Yes. 100%. So I think millinone should have been started. I agree with that. I think what they had at the back of their
Salman,
mind was
one minute, sorry. Salman, did
yes.
this thing that systemic vascular resistance is quite high? This is why you thought about millinone?
Yes, so I think it's a bit of both. We knew that we needed to support the RV. At this point, we realized it wasn't the LV, it's the RV is the issue. So to improve RV contractility, we wanted to use milrinone, and it would also take care of the SVR because, like you appropriately mentioned, that SVR obviously it's a dilator, so that would also be taken care of by the milrinone. And as is being evidenced, the SVR dropped from 2100 to 1300 in a matter of 2 hours. So
Salman, I just want to add one comment. Say when the patient is in the cath lab after 36 hours after reperfusion, even before getting the CVP, LVEDP, like we got the LVEDP, we know that the patient is already congested, ejection fraction is down by clinical. The thing is, like at that point, the blood pressure, even the soft, whether the patient got any diuretics. It's because the congestion eventually on the top of the decreased ejection fraction contributed everything. Even before starting the milrinone, so have you ever thought of the diuresis? It's because when we don't, so you got the diuresis.
yes, sir. So we actually gave the first dose of diuretic was given in the cath lab. First, when they first saw the right heart numbers, immediately they started him on Lasix. But the urine output was never really improving, not on the balloon pump, not on the Impella CP. But as we started the millinone, everything changed. The numbers, the output, patient appearance, everything looked good all of a sudden with millinone for 2 hours. And like Dr. Paul, sir, he was mentioning that, we should have started it sooner. I think the concern from the primary team, they didn't want to start it is because, again, it's ischemic cardiomyopathy. So they didn't want to start it right off the bat. But I think, honestly, looking at hindsight, patient would have done better if the millinone was started sooner. Definitely.
There is
and
no
numbers.
contraindication for, that you've been repeatedly mentioning that ischemic cardiomyopathy and millinone. There is no contraindication. I never heard of that. You cannot use the millinone on ischemic cardiomyopathy. Right. I know that you revascularize. There is nothing related to ischemic cardiomyopathy and millinone.
It's mainly the renal function. So it's not contraindication, but we have to be cautious.
Exactly. Yeah. It's exactly the cautious is the word. Like patient throwing off PVCs, NSVTs, then we get a bit concerned, but definitely not a contraindication. And I think, like sir had mentioned, that millinone could have been started sooner, but at least at this point, getting these numbers, we were happy with where we are. We decided to stay the course, close monitoring in CCU, and I will end my slides. I know Dr. Morshed sir has an important talk on cardiogenic shock. I will finish my slides after the talk. Thank you so much.
সালমান এক মিনিট সালমান ওই যে বলতেছিলাম যে তোমরা কিভাবে ডিসাইড করলা যে মিলিয়ন দিতে হবে
Milinon, yeah, it's because we wanted to support the RV. Like Dr. Paul was saying, that we initially thought it was an LV issue, but turns out it was an RV issue. So all we needed to do from the get-go was to support that RV. We kept on putting impeller, balloon pump on the left side, but we never really did anything for the right side. We thought, okay, this patient might end up with an ECMO or an RV impeller, but the guy's from India, he's only here for a business trip. Do we really want to put an ECMO? Let's give him a chance. Let's give him a chance for an hour or 2 hours of Milinon. What do we have to lose? So we thought it would improve the RV contractility. We thought it would also take off afterload reduction. And like Dr. Morshed sir was saying, he's congested. So we actually started preload reduction from before. So we wanted to with the Milinon, we wanted to improve the RV contractility and improve the afterload reduction with the SVR.
My
improving
question
the
to
SVR.
Salman, why not dobutamine?
I mean, I think that's a very good option. Dobutamine would have been a good option in this case, Munira ma'am. I think
But
there's
as because you are talking about the RV dysfunction and RV failure, I think Milrinone is a underrated medication, which actually, even though the Dorimi, the public report shows that dobutamine and Milrinone no difference with the outcome and mortality. Still, there is only concern was the renal function. If renal function is bad, you use the dobutamine rather than Milrinone. However,
right.
and the arrhythmia, if arrhythmogenic, more you switch to Milrinone. Not only this is the only difference about dobutamine and Milrinone in regards to renal function and the arrhythmia. I think there is another big difference, that is actually pulmonary arteriolar dilatation.
Exactly.
So
Yes.
it kind of, you are talking about RV impeller, but I think it worked as a kind of chemical version of the RV balloon pump, because it reduces the afterload and the pulmonary arterial dilatation so much. Rather than dobutamine, I think the Milrinone was the best option for this patient, especially whenever we are thinking about the RV dysfunction.
But just to clarify, as you mentioned, Dr. Munira, in the Doremi trial, there was no significant difference between dobutamine and Milrinone. And yes, perhaps because of its direct effect on the pulmonary vasculature, reducing its resistance, probably had some positive benefit over dobutamine.
Yes, sir.
That is exactly.
I assume that the patient is intubated at this point, is on mechanical ventilation, right?
So patient is completely on room air. He's almost laying flat, maybe 20 degrees. And that is what was always, concerning for us. Like, his numbers look so bad, but the patient is there. He's speaking to me in Hindi from time to time.
Looking back, do you think that was a good idea in a patient? Would you not like to reduce the work of breathing, maybe help in decongestions?
So,
And
Dr. Rahman, yes, sir. So he was
LV in his preload and all those things that you can get, and afterload that
right.
comes from proper use of mechanical ventilation and positive pressure.
He was on room air. He's on maybe 2 liters intermittently. He's breathing less than 20 breaths per minute. There wasn't any, we wanted to intubate. We're
I would assume
CCU,
that his
patients to be intubated.
respiratory demand on the heart was significantly high.
Right.
No
Right.
doubt about it.
No doubt, yes, sir. No, exactly. So we actually want to intubate the patient, but like I said, every time you look at the patient, talk to the patient, you don't think he needs to be intubated. So we just held off. And in terms of the Milrinone, I think both of you said it correctly. I think that was our thought process.
I mean, in general, in cardiogenic shock, you really want to, unless, A-B classification was a different story, non-invasive ventilation can still be considered, at least at the beginning. But by the time patients in frank cardiogenic shock, intubation and positive pressure ventilation is necessary. Okay,
Yes.
thank you, Salman, for your brilliant presentations. Now I'm going to request Dr. Ahmad Morshed to present the main topic. Thank you, Morshed.
Thank you, Dr. Lulubhai. Thank you, PHA, and thank you, everyone. And also thank you, Dr. Tasbirul, for giving me this opportunity. So today, our talk is about the management of cardiogenic shock in resource-limited setting. The talk is mainly based on 2025 concise clinical guidance. which is expert consensus statement on the evaluation and management of cardiogenic shock. So we'll talk about the definition of cardiogenic shock, staging, stepwise management, pharmacological.
মোর্শেদ তোমার স্লাইড দেখছি না।
স্লাইড দেখা যাচ্ছে না?
না।
Okay, great.
এখন দেখা যাচ্ছে।
Okay.
Good.
So we're going to talk about the definition of cardiogenic shock, staging, and stepwise management, pharmacological management, and temporary mechanical circulatory support. So we all know that CS is one of the most common cause of CICU admission, and short-term mortality is still 30 to 40%, and one-year mortality is still exceeding more than 50%. Since 1999, we have the shock trial, which presented that early revascularization improved the mortality. Still, for last 2 decades, we did not move significantly. But recently, the danger shock trial gave more information about the TMCS on the impact of mortality. If we look at the incidence, in this paper, it showed that in 2004, there was 122 admission per 100,000 hospitalization, and in 2018 it increased significantly. At that time it was like 408 per 100,000 admission. And if you look carefully, along with the MI cardiogenic shock, there is a significant increase of non-AMI cardiogenic shock. In the same paper also, we saw there is a in-hospital mortality improvement from 49 to 37%. So there is a case, I think 2 weeks back, I have a patient, 68 years old gentleman, came with a severe central chest pain, blood pressure was 180 over 90 millimeters of mercury, tachycardic. EKG clearly showed anterior STEMI. The patient has a chest pain for 6 or 7 hours, and the patient got primary PCA. After reperfusion, the blood pressure got better, but more tachycardic, and he was more diaphoretic, though he was not telling that he has chest pain. The question here is the patient is in shock, whether pre-shock, and what to do next. So let's talk about the definition. As per SHARP, there's 2 types of definition. One is the definition for the trial, and another is the definition for the practical medicine. Since the beginning of the shock trial in 1999, and most of the trial actually, including IBP shock, ESC guideline, they incorporated mainly 3 things. One is the hypotension, hypoperfusion, and also the hypoperfusion, the lab sign, and hemodynamics. But when we are doing the trial, what we found eventually that we are missing a big category of cardiogenic shock, which is normotensive cardiogenic shock, which happens in 1 in 5 patients, and actually about 20% of the CS patient population is normotensive CS. In this paper, there was it showed the trajectory of hypotensive cardiogenic shock and normotensive cardiogenic shock. If you look carefully, most of the hypotensive cardiogenic shock already presented around in stage C, but normotensive cardiogenic shock presented in stage A and B, and they stayed in A and B around 12 to 24 hours before death. And then the progression of a stage C to D, and also in normotensive cardiogenic shock from a stage C to D, is nearly comparable, about like 58% versus like 51%. So we often miss the normotensive cardiogenic shock when we think only about the hypotension. So that's why the SHARP came up definition of CS by clinical practice. So there is a 3-point is very important here. One is the sustained tissue hypoperfusion, irrespective of blood pressure, and lactate is the backbone of the stage C of CS, along with the multi-organ dysfunction. So remember this thing, it's a cellular level of hypoperfusion, which represented by slowly and gradually increased lactate, And irrespective of the blood pressure, even with the normal blood pressure, patient can have cardiogenic shock. So let's go through the pathophysiological features of the cardiogenic shock. So it's a downward spiral of the vicious circle of primary cardiac insult. So once there is a cardiac insult, it can be myocardial infarction, it can be de novo heart failure, or it can be old chronic heart failure, and there is some insult on the top of that, which causes decreased cardiac output, decreased blood pressure, and increased vasoconstriction, eventually lead to increased volume overload and organ perfusion decreased, leading to multi-organ dysfunction. Unless we intervene, eventually the patient die. So what are the major categories of CS? There are four, but mainly MI cardiogenic shock and heart failure cardiogenic shock. And MI cardiogenic shock also usually two categories. One is the ST elevation MI, another is non-ST elevation MI. Heart failure, usually de novo heart failure, which is acute onset, and another is acute and chronic heart failure. We often get a call from the ED or ICU. The patient has in cardiogenic shock, along with the troponin is trending high, whether the patient needs to go cath lab for the primary PCA. So the shock trial showed, so here most important thing is to see the EKG changes, especially ST elevation. The ST elevation, in ST elevation, early revascularization improved mortality. But in other three, the culprit shock trial also showed that non-STEMI, de novo heart failure, or acute and chronic heart failure, the catheterization actually increased the risk of mortality, worsening of the mortality. So if we look at the incidence over time in USA, also along with the MI cardiogenic shock, the heart failure cardiogenic shock was increasing significantly. I think last census is about like near 48 to 50%. So it's touching nearby, as because increasing the comorbidities, elderly patient, and chronic heart failure patient population. So initial diagnosis of the cardiogenic is extremely important, as we saw in the case. So once you see clinically the patient is in cardiogenic shock, you need to act upon as early as possible. This is a 24-hour roadmap. We cannot sit on that. There is a pneumonic suspect CS. Usually the patient presents with like altered mental status, diaphoretic, chest pain, short of breath. Even in the cath lab, they can be transferred from immediately from normal condition to this type of symptom, along with the nausea, vomiting, abdominal pain. Urine output can decrease. There is a sustained hypotension and also hypoperfusion, EKG change of, and we can get the bedside echo. It's better to get the bedside echo if possible, but that can show some changes too, and along with the congestion. The minute we suspect it's a cardiogenic shock, the next step is as early as possible to do the SCAI staging and also follow the trajectories of the staging. And also simultaneously, we have to triage the patient. We have to decide whether the patient will go to the cath lab, the door to balloon time, or whether the patient will go to CICU, or whether the patient needs to higher level of care to transfer to the other hospital. I'm going to talk about the SCAI staging a little bit later. So again, early diagnosis of CS and starting the management immediately is extremely critical. And presence of hypotension, we often rely more on hypotension rather than other numbers. So here, the definition of hypotension is systolic blood pressure less than 90 millimeters of mercury, mean arterial blood pressure less than 60 millimeters of mercury, and also it can be more than 30 millimeters of drop from the baseline for more than 30 minutes, along with tachycardic. As in septic shock, we often rely, and especially in ICU, we often see the nurses and the ICU team often rely on the mean arterial blood pressure. But in cardiogenic shock, often the mean arterial pressure is kind of elevated due to increased SVR, increased vasoconstriction, and also narrow pulse pressure. So mean arterial blood pressure is not a very good indicator in cardiogenic shock rather than systolic blood pressure. So in 2019, when FSCAI came up with the staging of the shock, cardiogenic shock, and since then we are trying to talk in same language. This is extremely important when we are trying to same language, then the other like faculty and also the other hospital can understand what we are exactly dealing with and what's the trajectory and what next should be done as early as possible. So it's A to E. A means at risk. Possibly the patient has a acute myocardial infarction, but all the numbers, including blood pressure and lactate, is normal. B is the beginning, where the patient lactate is normally still not tissue hyperfusion, but the patient can have hypotension. Especially in the B, patient usually have congestion. And that need to be addressed as early as possible. If we don't address, eventually it increases the microcirculatory ischemia and further downward spiral to the rapid progression to other stages. Stage C is the classic, where there is a hypoperfusion. Lactate is usually more than 2 millimole, along with hypotension plus minus organ injury. And here the patient needs intervention, starting with the low to medium dose of norepinephrine and or TMCS, and follow up with the trajectory of the shock. D is the deteriorating, usually stage C plus, despite intervention of the pharmacotherapy and or TMCS, the patient is still deteriorating. Usually patient requires 2 or more inotropes, plus minus 1 or 2 temporary MCS, and extremis, E for extremis, where usually patient is nearly circulatory collapse or impending collapse, cardiac arrest, and also lactate is usually more than 8 or 10, and severe metabolic acidosis. The patient usually require at least 3 or more inotropes. So to put in summary, like the very important here is to see the lactate and along with the other numbers. So once lactate is elevated or about to be elevated, this is already classic shock, and we need to intervene as early as possible. If we not, then it will deteriorate so fast. And at that time, we will not have enough time. So then cardiogenic shock working group puts some more criteria, which are like cardiac index from the hemodynamics, CVP, pulmonary capillary wedge pressure, PSAT, everything. But again, in the C, lactate is elevated, but before C, lactate is not elevated, along with the worsening of others number. So let's talk about the trajectory of the shock. A patient came, maybe that patient, the blood pressure is already 80/60, tachycardic, and we got the hemodynamic numbers, and cardiac index is less than 2.2, capillary wedge pressure is 27, lactate is 3. We started the norepinephrine, medium dose 0.3 mic per kg per minute. So what's the stage? Stage is C, already lactate is elevated, hypotensive, hemodynamic number is getting worse. And with the norepinephrine, and in ICU, the patient, they increased the norepinephrine to 0.5 mics per kg per minute. And after 1 to 2 hours, still the patient is not getting better. Lactate is going high, capillary wedge pressure is going high. So the patient is progressed to stage D. At that point, the patient got Impella or some like TMCS, and then after 2 to 3 hours, the lactate is getting better. Capillary wedge pressure is 25. So means the patient trajectory is going toward improvement. Is from the stage D, now is going back to stage C. So here 2 number is extremely important. One is the lactate clearance, another is the SWAN number, especially pulmonary capillary wedge pressure, cardiac index, CPO, for the right side RA pressure, PAPI. So while we are doing triage, there are a couple of questions need to be asked and answered. What is the FSCAI stage at this moment? Whether the patient need or require escalation of the TMCS, as we saw when the patient was getting worse in the cath lab, the question is whether we should escalate to TMCS or we will wait, and what type of TMCS, and also whether there is any absolute contraindication to the escalation of the treatment, say, for example, DNR, terminal illness, very advanced dementia, others, and whether our hospital has the resource to support the patient's anticipated need. And also we have the collaboration with the other hospital where we can transfer. And also the patient is hemodynamically stable for transfer or not. So there is a proposed CS level hospital from 1 to 3. 1 is the highest level and 3 is the lowest level. So 3 is the hospital who can only diagnose cardiogenic shock. They don't have cath lab, so they cannot take care of the STEMI, and they need to transfer the patient. And level 2, usually they have the cath lab, they can take care of a STEMI, PCI, and plus minus. Actually, TMCS depends on the operator expertise and comfortability. And level 1, they have all aspects of cardiogenic care, and also there is a surgical and percutaneous availability of TMCS. Sometimes those hospitals can have durable LVAD and heart transplant capabilities. So a study showed that CS team activation actually improved the outcome. There is a multicenter observation and analysis showed when there is a CS team available along with the activation, usually those patients in these places get like invasive hemodynamics and advanced, they get more advanced type of TMCS, like temporary mechanical circulatory support, and also CICU mortality is improved. And who is the team member of the CS team? It can vary from hospital to hospital, but usually it starts from the ED attending, and then interventional cardiology, ICU attending, general cardiology, heart failure cardiology, and also advanced heart failure cardiology and CT surgeon, and so on. In this paper, they showed that with the shock team, there is the improvement in mortality, especially if you see this dark blue is the shock team and the light blue is the no shock team. And with the shock team, there is more, so they got more PA catheter numbers. The overall MCS is less, but advanced MCS is higher in those hospitals, and overall CICU mortality is better, which was published in 2021. So if we put all together, there are a couple of things is extremely important. The minute we see the patient, we diagnose the CS, we need to ask whether this is the right patient for giving the treatment, taking to the cath lab or further escalation, whether this is the right time and what stage the patient is on, and whether this is the right place, whether the hospital has enough capabilities or resources to take care of this patient, and what is the right treatment at this moment. If we put all this together, then we can make a better outcome of this patient. So invasive, let's talk about the invasive hemodynamics. In stage A and B, usually invasive hemodynamics is not necessary to diagnose. Usually most of the CS diagnosis is clinical along with the labs, but observational data showed there is an improvement of actually outcome if it is used C and bute, stage C and beyond. So hemodynamics will tell us what is the phenotype of CS, whether it's LV dependent, RV dependent, or BIV dependent. What's the severity of shock and what's the trajectory? And whether it will guide also the rapid escalation to TMCS and waning decision. This paper actually showed was the difference between the complete hemodynamic profiling with the PA catheter versus incomplete hemodynamic profiling or none. So none is the blue color, and then this is the incomplete assessment where they did not get the RA pressure, and complete assessment, all the PA systolic, diastolic, wedge pressure, saturation, along with the right atrial pressure. And overall mortality is better in when there is a complete hemodynamic assessment of the shock even in the stage D and stage E, where stage E has the 70% mortality by itself. So in my center, actually, we do one thing. The minute the patient comes with a MI STEMI, so either before or after, we always get the right heart catheter. That's the baseline, even the patient is A or B. And the CICU is told that they cannot take any patient without having the right heart catheter number. And the minute the patient is either lactate is elevating or the patient is not looking good, so we put the SWAN leave-in and continue the monitoring of the SWAN number every 1 to 2 hours, especially around 2 hours. And then our nurses are actually well trained about the numbers. So here, another factor is very important, as we saw in our case. In right ventricular dysfunction is very common in those patients, and actually it increased the risk of dying. This paper published. So, and usually it happens 1 to 2 out of 5 patients, there is a RV dysfunction. So we should not miss that. So there are a couple of hemodynamic parameters which are associated with adverse mortality, which is low mean arterial pressure, as we all know, elevated RA pressure to pulmonary capillary wedge pressure ratio, and reduced PAPI. The PAPI usually tells us about how is the RV contractility, the pulsatile load, RV congestion, but usually it is more useful in the setting of elevated RA pressure more than 10 millimeters of mercury in the absence of moderate to severe pulmonary hypertension. So low PAPI, as we mentioned before, if it's less than 0.9, it means there is a significant RV dysfunction. Regarding the monitoring, we do along with all the monitoring, clinical, lab, blood pressure. But the two important thing for the monitor is the check the lactate, is because usually these patients have either IV line or central line. So every 2 to 3 hours, check the lactate, see the trajectory, and get the SWAN number. The patient should be on SWAN-in, so get the numbers and act on that. We always tell the ICU and CICU team, don't act on mean arterial blood pressure. Don't act on blood pressure, systolic blood pressure on itself. You're to act on actually on the SWAN numbers along with the lactate. So usually what happens very often, the nurses act on the blood pressure, the mean arterial blood pressure. Eventually the patient end up into 2 or 3 inotrope, which actually increase the mortality. So let's talk about the pharmacological management, which is still number one treatment at the very beginning and sometimes all the way at the end. This paper is a very comprehensive study about the medical therapy of cardiogenic shock. So what is the goal of pharmacological therapy? 3 goals. One is to decrease the congestion, to improve cardiac output, again, to improve the perfusion. And as I said, whenever the patient is in stage B, most often the patient has a congestion. Sometimes it's subtle congestion, sometimes it's very obvious congestion, and we need to address that as early as possible. First, we can try with the diuretic. If diuretic doesn't work, along with the inotrope, we can try with the diuretics. If it's not addressed, it increases the microcirculatory ischemia and further rapid progression to the stage C and further. So as per expert consensus, the norepinephrine is the first line of the drug. Now the question is why? There is multiple trial head-to-head, but there is not enough data that any of these inotrope is superior to the other inotrope. But what all the studies showed that norepinephrine somehow has lower adverse effect. Norepinephrine usually alpha will act on alpha receptor and also on beta 1 receptors, so increase SVR, increase heart rate, increase contractility, increase cardiac output. Dobutamine is mainly beta agonist, so it increase heart rate and myocardial contractility. By that, it increase actually the cardiac output. Epinephrine actually dose dependent. So in low dose, it is act on the beta receptor. In high dose, it acts actually on alpha-1, and also it act on liver, which increase the risk of lactic acidosis. Dopamine, sometimes we tell it's a devil drug. It's a more of dose dependent. In renal dose 1 to 4 mics, it works mainly on D1, and then in medium dose 5 to 10, it works on beta receptor, and also high dose, it works on alpha-1. Milrinone on the other side, the interesting thing is it's a phosphodiesterase type 3 inhibitor. It doesn't work on any receptor directly. So what happens when there is a ATP to cyclic AMP, which is done by adenylate cyclase, which increase the protein kinase A, so which decrease the systemic vascular resistance and decrease the afterload, along with it increase the cardiac output. What milrinone does, milrinone inhibit this phosphodiesterase type 3 enzyme, and the minute this enzyme is inhibited, the cyclic AMP go up, and which will eventually decrease the systemic vascular resistance. Next question is, which drug we usually start or we should start? So first line drug is norepinephrine, and along with the, if we need to add other medication, we usually prefer dobutamine over milrinone. The reason is dobutamine is short acting, especially in this type of patient, cardiogenic shock, the dynamic hemodynamics. So we need to titrate very fast. We need to see the effect very fast. And if we need to stop, so the minute we stop, it takes only 5 to 10 minutes. And on the other side, milrinone can be also like along with without dobutamine, but milrinone has some problem. The downside, it has a long half-life, and also it is renally excreted. Especially in this type of patient, we don't prefer, but it can be used definitely. And another thing is very important. When we start any single agent, it should be started with the lowest possible dose, with a shortest possible duration. Often we see in the ED, the patient is already started with the norepinephrine high dose, and in the ICU, it is kept for a long period of time. The minute we go to the low to medium and we have to see how is the trajectory, then we have to move on for the early MCS. So this is the same mechanism of action. There are multiple trials. The SOAP trial in 2010, dopamine versus norepinephrine, no significant difference, but in dopamine group, there is more arrhythmic events. In CAT and Optima CC trial, which also between epinephrine and norepinephrine, no significant difference, but there is a significant tachycardia and lactic acidosis with epinephrine. There is a Levy et al. In 2011, norepinephrine dobutamine versus epinephrine, and which also showed in epinephrine group, there is a significant lactic acidosis, decreased splanchnic perfusion, and tachycardia. So as I mentioned before, so the reason the expert consensus choose the norepinephrine, not for the mechanism of action, but mostly the less adverse effect in comparison to the others. So there is a DOREMI trial, as we talked about this, like milrinone versus dobutamine. There is no significant difference in primary outcome or the secondary outcome. Only the difference, what I said before, that is a short half-life for dobutamine, so we can titrate easily and not renally excreted. Milrinone is actually long half-life, difficult to titrate, and also this patient usually have the renal injury, or the patient sometimes have the CKD, so acute on CKD, so renal excretion, we have to be judicious and cautious. Let's look at this chart. So the minute there is a mean arterial pressure decreased, there is an increase in systemic vascular resistance, and which is compensatory. At this point, we started the inotrope, which increased the vasopressor-induced vasoconstriction. We all are happy that blood pressure is getting better, but eventually at certain point, there is a mechanical insufficiency, is because there is an auto down regulation of the receptor. Even we increasing the dose of the inotropes, the patient is not getting better. And eventually there is a vasoplasia, which leads to organ injury, microcircuit dysfunction, tissue hypoxemia, eventually death. That's why even for last 30 years, we are using inotrope. The patient is not getting better and the mortality is not getting improved unless we act on early with the temporary MCS. So as I mentioned before, the first-line therapy by expert consensus is norepinephrine, next is dobutamine or milrinone, and dopamine sometimes we use, but dopamine increased. It's a very difficult to titrate. It's a dose dependent and increased significant arrhythmia. So let's talk about a little bit of early revascularization. The shock trial in 1999 showed early revascularization improved the mortality. And if we look at this study in 30 days, the line was divergent, but it was not statistically significant. But in 6 months, there is in medical therapy, there was a 63% death, but in revascularization was a 50.3%, which is statistically significant. So let's talk about the temporary mechanical circulatory support. What are the support device we have? So when we think about the support device, we have to think in a way whether which device support the LV, which device support the RV, and which device can support the both. Let me tell you, so these devices doesn't come without the complication. It comes at the expense of complication, but we, before it was more of psychological benefit that when inotrope was not helping, we jump on the impeller. So, but now there is a trial, danger shock trial showed significant mortality benefit. So balloon pump was the earliest one, which actually improved only 0.5 liter. And in MI cardiogenic shock, it is really not responsive that much. The mechanism is actually balloon inflation and deflation, and it's an 8 French sheath. We usually place it through the femoral artery. It does not unload the LV. It decreases the afterload a little bit, increase the coronary perfusion. Especially on MI cardiogenic shock, it doesn't do much. Next is the impeller CP and 5.5. So impeller 2.5 was in the market, but now impeller 2.5 literally no one use. Impeller CP is actually axial, microaxial flow continuous pump from LV to aorta. The inlet is in the LV, outlet in the aorta, and it's a large French, which is 14 French arterial pilloway sheath. We usually place through the femoral artery, and the major benefit is direct LV unloading. In couple of center, actually, when the MI cardiogenic shock comes, they were checking whether LV unloading before the revascularization or not. And then impeller 5.5, which actually maximum flow of like 5 to 7 liter per minute, but the sheath size is huge, and usually like it is 24 Frenches, and we need surgical cut down. They usually put through the axillary artery. And as more and more large bore, that increase the risk of vascular complication, bleeding, limb ischemia, hemolysis, renal failure, and also stroke. What about RV support? Usually impeller RP flex. It is actually the continuous pump from RA to PA. So inlet in RA and the outlet is in the PA. 23 French sheath, it can be placed through the internal jugular vein or femoral vein, and it unload the RV. And VA ECMO, which is actually speed is low, and large French, it's an arterial sheath is around 24 French, venous is 25 French. The blood is drained through the femoral vein, from the femoral vein, and return through the femoral artery. But it increased the afterload. Usually when we put VA ECMO, we need impeller to unload the LV. Otherwise, it doesn't work very well. So let's talk about the trials about this all temporary MCS. So IBP shock trial, over 30 days, if you look at it carefully, there is no significant benefit. And even after 6 years, there is no significant benefit. And then ECLS, life support in infarct-related cardiogenic shock, the lines are converged, so there is no significant mortality benefit. But recently, last year, which was published this year, danger shock trial. So it came, and it is a randomized controlled trial, enrollment for 10 years. And if you look at the inclusion criteria and exclusion criteria, that made the difference between this trial with the IABP trial and ECLS trial. They took only the STEMI, and it was done in Danish and Germany and one center in the UK. They took cardiogenic shock, they took hypoperfusion, ejection fraction less than 45%, and they randomized when shock diagnosed. But the most important is they did not take comatose patient after out of hospital cardiac arrest. They did not include RV failure, mechanical complication, and also non-STEMI, and the shock duration over 24 hours. As I said before, so early diagnosis of the shock is extremely important. Early intervention is extremely important. We cannot sit. It's not over several hours. It should be 1 to 2 hours. And this trial showed actually absolute mortality reduction in 80 days, 12.7%. And number needed to treat is 8. Means to prevent one death, if we need to treat 8 patients. And then when they did subgroup analysis, so that's another amazing thing, that number needed to treat went down to 5. So to prevent one death, we need to treat only 5 patients, which is very rare in medicine. Now, the next question is, the danger shock trial showed this, but IABP and ECLS trial did not. We don't know exactly what's the reason, but there are a couple of things. In both IABP and ECLS shock trial, they included this cardiac arrest patient. And those comatose out of hospital cardiac arrest along with the comatose. So we all know that when the patient has out of hospital cardiac arrest and the patient GCS is less than 8, major mortality comes from neurological. And also they included a big number of non-STEMI. But we don't know. But this is the first trial which showed temporary mechanical circulatory support improved the mortality. So in ICU, a couple of things we need to monitor. First of all, the hemodynamic support is adequate or not, whether the reversible causes is addressed or not. There is a complication of TMCS, and if necessary, whether it is treated or not, how management of the end organ injury, and when to de-escalate, and the coordination of the interdisciplinary decision. So let's put some take-home points in every setting. The early diagnosis and intervention of the cardiogenic shock is extremely important. Lactate should be checked for every cardiogenic shock. Right heart catheter has significant benefit in a stage C and beyond. The minute cardiogenic shock is diagnosed, we need to do the SCAI staging and check the trajectory. Rapid escalation and de-escalation of the TMCS is extremely important. And first 12 to 24 hours is very critical. Once you lose that period, most often you lose the patient. And vasoactive medication should be started with the lowest possible dose with shortest possible duration. The minute norepinephrine goes like a low to medium and then high dose, we need to decide rapidly whether the patient needs TMCS or not, and which type of TMCS is necessary at this point. Another very important point, balloon pump is not very much sensitive in MI cardiogenic shock. And another very important thing is increasing the vasoactive medicine dose and duration, increase the mortality, as I showed before, that eventually there is a vasoplasia. Even though we are increasing the dose, there is no benefit. And early revascularization improve mortality in MI cardiogenic shock, and Impella improves mortality in not all STEMI patient, in select STEMI patient when it is used earlier, not after 24 hours. So in the limited setting, along with all, I know Impella is not available in Bangladesh and other limited resource setting. But the very important is the minute we diagnose, we need to have a SCAI staging. If possible, to build a shock team. If we have all these number, even though we don't have the resource, they can build the shock team. So like a heart team approach, and also inter-hospital and intra-hospital collaboration. What we have and what we don't have, whether we can transfer to the hospital and whether our communication with the other hospital is clear upfront. I think in a summary, I was put the first diagnose the cardiogenic shock as early as possible, and the minute diagnose, do the staging, activate the CS team, triage the patient, whether the patient will go to the cath lab, CICU, right heart cath, or the higher level of the care. And along with the hemodynamics as a baseline, and if it's a stage C or beyond, get a SWAN in situ and start with the low dose of the inotropes. First line is the norepinephrine, and rapid escalation in 1 to 2 hours. Don't sit over that. And the monitoring is mainly by SWAN numbers and the lactate numbers. And de-escalation. In our center, we usually, most often our protocol is actually we do Impella for full speed for 48 hours. And the minute we start Impella, we try to cut down the inotropes. And after 48 hours, we win. Thank you so much. So I think...
Thank you very, very much, Dr. Morshed, for this rather intriguing, brilliant presentation. As you rightly mentioned, we often do not think about the possibility of microcirculatory shock. Our concept revolves around the macrocirculations, mean arterial pressure, and so forth. Or one can have even high blood pressure, not even normal, and can be in profound microcirculatory shock. And as you mentioned, 1 in 5, especially in cardiogenic shock. It may not be as true in the setting of septic shock or other kind of shock, or neurogenic shock, etc. But certainly for cardiogenic shock, where the compensatory mechanism is fully intact, and there could be a disconnect between the macro and micro circulations. So that is something for us to remember. And so therefore, the old school clinical methods like capillary refill time and mentation and urine output, certainly lactate at this level starts to rise, but may not be immediately evident. Skin, temperature, all those things still remains extremely relevant. In the resource-limited settings, when you have immediately, I agree that especially in very sick people going into shock, impending shock, this Swan-Ganz catheter, timely placement can be extremely helpful in guiding the therapy. But for the critical care physicians, bedside point of care ultrasound, and I would like to get your comment on that. Looking at both RV and LV function, maybe a guesstimate of the left atrial pressure, pulmonary venous flow measurement, lung water content, the B lines, etc., IVC, and integrating all of them, and at the same time taking into consideration the biochemical and the clinical progress, one can make the decision about the urgency of the intervention, because time is the key, as you rightly mentioned. So I guess that is something I would like to hear some comment from the critical care physicians and also, of course, from the cardiologists soon.
Sir, I want to
yes.
share one of my cases in our settings, really resource limiting settings. You mentioned that we have to refer in different hospital, but for management of cardiogenic shock, even the private centers have nothing extraordinary facilities. So few days back, the patient came referred from another centers, cardiogenic shock STEMI for more than 48 hours. Anterior STEMI, and patient with 1 inotrope support, patient admitted in a private center where I am practicing. Then what we can do, we just escalating the dose of norepinephrine, and what we do that within 60 minutes we want to send him to the cath lab, and during the cath lab, the patient cannot lie down flat. So I asked the anesthesiologist to put him in ventilator, and then I do the PCI, the LED opened with a drug-eluting stent, and the patient was on ventilator for more than 6 or 8 hours, and then ventilation off, and gradually after probably 18 hours we can taper off the norepinephrine, and the patient has went back to home after 6 days. So we have very few centers have few IABP, but that is not in use for cardiogenic shock patient. So what we can do the diagnosis of shock early, and we can put the patient revascularization early. Because if we can revascularize, that is the only options do early for a cardiogenic shock patient. But what the irony of fate is that we are fear about do the intervention in a cardiogenic shock patient. They are high mortality, and even the danger shock trial have 50% mortality around it. Even all facilities, they are 50% mortality. So what we are feared about that the patient party will not understand the fact that we are doing something for the patient, even though there is a 50% chance of mortality. So the people are not interested in do intervention in a cardiogenic shock patient, but in our resource limiting setting, I think that is very important. Intervene early to open the artery. Thank you.
So I completely agree with you. I think that is the biggest tool, and not only over there, also here. And the fear of taking this patient to the cath lab is everywhere. Here in USA, when we take the patient at this point, if the patient died, so the mortality comes along with our name that the patient died in the cath lab. But again, like it's showing significant improvement of mortality over the years, over 20 years. Thank you.
Thank you so much, Dr. Momin, for sharing your experience, especially in the resource settings where you're working. I would like to request Dr. Rajuddin to share his comments and experience that he has from his own center.
Thank you, sir, for your kind permission, and I would like to thank first both the speaker, Dr. Salman and Dr. Ahmad Morshed, for their excellent presentation. I am an intensivist working in Square Hospital, Dhaka, Bangladesh. So mainly apart from the like acute myocardial infarction or having this cardiogenic shock, what we are dealing is like first the patients who are in shock, especially compromising both septic and cardiogenic, we are observing the patient bedside. Then we have this arterial line, then this focus to treat him, to give him fluid responsiveness or no. Later, we are using this hemisphere. I think if it is using in USA or other countries like this, like TICO. So the hemisphere is showing us the SVRI, cardiac index, cardiac output, and it's very easy to use because it needs an only arterial line, and in some precondition, of course, you have to keep the patient fully sedated and ventilated. So this is the one thing we're using in our hospital. And this is the, in our Square Hospital, we are the only one having the ECMO in Bangladesh. So last almost 4 years, we have done almost 10 cases. Mostly it was ARDS with septic shock. So mostly it was used as a VV ECMO. But last 2 months before, we had a case of myocarditis due to influenza A virus. And this patient was in severe shock, and we started on him on VA. And the patient improved, but as you know, the cost of ECMO is expensive, very expensive for many people here in Bangladesh. We don't have that much of funding. So at the end, we could not continue the process. But what we have seen that after we put the patient on ECMO, the hemodynamic stability was improved significantly and dramatically. And also the perfusion, tissue perfusion and others also was improved. So what I think in Bangladesh, as Dr. Momin sir has mentioned, that Impella and all these devices is not available everywhere, even in the tertiary care center. It is very difficult for us to go for the interventions. So as an intensivist, we are depending on the bedside tools, and then we have this arterial line and this hemisphere. And at the end, we are trying our best with the VA. Still, we are not so expert, but we are trying our best to Square Hospital to serve as much as possible. But you know, the financial condition is a big barrier for us to start the patients on VA. So thank you so much from my side. And if anyone have any questions, we can share and more. Thank you. Thank you, sir.
I have another comments about the hemodynamic measurement during the primary PCI. The only thing what we can do, because we have no Schwann-Gauss catheter even. So what we can do that we check the LV EDP during the primary PCI. So that is the only tool which help us a lot that the patient is in failure or impending failure.
Correct.
Thank you, Rajuddin, for your extremely relevant contributions and your own experience in your center. It's nice to know that you are going to start VA ECMO and hopefully you'll build experience over time. I would like to go to Dr. Matiul Islam to share his comments and own experience in his center. Dr. Matiul Islam, are you there?
হ্যালো, আমার কথা শোনা যাচ্ছে?
Yes, please go ahead. Thank you.
রাইট, কথা শোনা যাচ্ছে এখন, তাই তো?
Yes, indeed.
Okay, right. Thank you both the speakers for their excellent presentation. যদিও আসলে আমি পুরো সময়টা থাকতে পারিনি, প্রেজেন্টেশন শুরু হওয়ার পর আমি একটা ইমার্জেন্সি পেশেন্ট কলে চলে গিয়েছিলাম। তো আমি শেষের অংশে ছিলাম। আমি যেটা বলতে যাচ্ছি আসলে আমি যেটা হচ্ছে যে টেক হোম মেসেজ যেটা দেখলাম, আমি আসলে স্পিকারের শেষ কথাগুলোর সাথে আমি খুবই একমত। আমরা রিসোর্স লিমিটেড সেটআপে থাকি বা যেখানে থাকি না কেন, উই হ্যাভ টু স্টিক টু দ্য বেসিক। আমাদের কাছে যেই রিসোর্স গুলো আছে সেগুলোকেই ঠিক মতন কাজে লাগানো। যেমন রিসেন্টলি আমরা ক্রিটিক্যাল কেয়ারে ফোকাস পয়েন্ট অফ কেয়ার আল্ট্রাসাউন্ডকে আমরা খুব বেশি গুরুত্ব দিয়ে আমরা কিন্তু লট অফ কেসেস আর্লিকে পিক আপ করতে পারি ফর দ্য ডায়াগনোসিস। এটা আমাদের এলভি ইজেকশন ফ্র্যাকশন দেখেও যে আমরা সবটা রাইজ করতে পারি। জাস্ট ডে বিফোর ইয়েস্টারডে একটা কেসের কথা আমি বলি। এই পেশেন্টটা ভর্তি হয়েছিল হচ্ছে সিসিইউতে, তাদের ট্রপাই বেশি হয়, ইট ওয়াজ ডায়াগনোস অ্যাজ এ কেস অফ এমআই। বাট তাদের কাছে তারা আমাদের কার্ডিওলজি একটু সন্দেহ করলো যে মানে এলভিএফটা তাদের কাছে মনে হচ্ছিল যে ওইরকম এক্স রে সাথে ওদের কাছে মনে হচ্ছিল না, যে পরিমাণ শ্বাসকষ্ট সেরকম এলভিএফ ওরা দেখে পাচ্ছিল না। এবং হি ওয়াজ অন ডায়াবেটিক্স এবং হচ্ছে পেশেন্ট ওয়াজ গেটিং আ লিটল বিট অফ লো বিপি বাট হাইপোক্সিয়া ওয়াজ মেইন। পেশেন্ট ওয়াজ হ্যাভিং চেস্ট টাইটনেস। তো আমাকে যখন ডাকলো, হোয়াট আই ডিড, আই পুট দ্য প্রোব অন দ্য চেস্ট এবং আমি দেখলাম যে তার ওয়াজ আ বিউটিফুল টি শেপ, তার হচ্ছে আরভি স্ট্রেন আছে। তো আমি বলে ফেললাম যে আসলে এটা ইটস মোস্ট লাইকলি পালমোনারি
How was the
এমবোলিজম।
lung findings? Did you find lung
ইট ওয়াজ অলিগ্যামিক লাং ছিল, অলিগ্যামিক লাং ছিল।
আচ্ছা।
তো আলটিমেটলি আমি বি লাইন খুব একটা ছিল না আর কি, মানে অলিগ্যামিক ঠিক বলবো না, মানে বি লাইন ছিল না। হ্যাঁ, তো পরে আমি জাস্ট কোনো মতেই পেশেন্টটাকে আমরা সিটিপিএ করতে পারলাম এবং দেয়ার ওয়াজ আ মানে বিগ বায়োল্যাটারাল পালমোনারি এম্বোলাস। তো পেশেন্টের আলটিমেটলি যেহেতু তার হাইপারটেনসিভ পেশেন্ট এবং বিপি ওয়াজ অন দ্য লো সেট, তো আমরা থ্রোম্বোলাইসিসে গেলাম। তো হোয়াট ইজ দ্য প্রবলেম, যেমন আমি বাংলাদেশের অন্য ডাক্তারদের সাথে আমি একমত যে যেমন আমাদের হসপিটালেও হচ্ছে আইএবিপি আছে, বাট এই আইএবিপি হচ্ছে আমাদের থাকে হচ্ছে কার্ডিয়াক সার্জনদের আন্ডারে। তো আমরা ডায়াগনোসিস অ্যাপ্রোপ্রিয়েট করে আমরা হয়তো থ্রোম্বোলাইসিস করছি, সেটা আমাদের হাতে থাকে। ইভেন আমাদের ক্যাথ ল্যাবে আমরা পেশেন্টকে নিয়ে যেতে পারি, আমাদের ডায়াগনোসিস হলো, এবং আমাদের কার্ডিওলজিস্ট কলিগরা এখন ভেরি হেল্পফুল। 24 আওয়ার্স হয়তো আমরা প্রয়োজন হলে এমআই থাকলো আমরা ওপেন করতে পারছি। বাট আমাদের যেটা হয় যে এই যে ভেন্টিকুলার অ্যাসিস্টেড ডিভাইস, এগুলো আসলে আমাদের এখনো অ্যাভেলেবেল না। স্কোয়ারে যেমন এখন স্টিল তারা ইকমো দিতে পারছে, বাট উই আর নট ফরচুনেট এনাফ যে আমরা এখনো ইকমো প্র্যাকটিস করতে শুরু করতে পারিনি। বাট আমি গত 2 বছরে আমি 2টা পেশেন্টকে মাত্র আইবিপি সাপোর্ট দিতে পেরেছি, এবং 2টো পেশেন্টেরই আউটকাম এক্সিলেন্ট। বাট প্রবলেম হয়েছে যে আমাদের যে পরিমাণ আমাদের পেশেন্টদের ক্যাপাসিটি, সেইখানে আসলে সার্জনদের বাইরে অন্য একটা আইবিপি এনে আমরা হসপিটাল বাজেটকেও বুঝাতে পারি না। তো আসলে আমার কাছে মনে হয় আমরা যদি বেসিকে স্টিক করি, আর্লি ডায়াগনোসিস, এবং শুধু সেটা পিওর কার্ডিওজেনিক শক কিনা, এটা একটা। আর আমি একটা জিনিস আমি খুবই বিশ্বাস করি যে আমাদের মতন রিসোর্স লিমিটেড সেট হোক বা যাই হোক না কেন, লো রিসোর্সেও কিন্তু আমরা ইনভেসিভ ব্লাড প্রেশার মনিটরিংটা চালু করতে পারি। দেখা যাচ্ছে আমাদের প্রায় সময় কিন্তু আমরা হয়তো বাংলাদেশেও ম্যাক্সিমাম জায়গাতে এখনো ইনভেসিভ ব্লাড প্রেশার মনিটরিংটা এখনো ওভাবে পপুলার হয়নি, যেটা হয়তো আমরা করছি, আজগলিতে করছি, হয়তো স্কোয়ারে করছে, বা ইউনাইটেডের কয়েকটা সেন্টারে করছে, বাট অনেক জায়গাতে এই প্র্যাকটিসটা হয় না। তো এর ফলে যেটা হয় যে ধরুন আমরা যে আয়নোট্রপ সাপোর্ট, অনেক সময় হয় না যে আমাদের পেশেন্টকে আমি হয়তো নরএপিনেফ্রিনে আমি যাচ্ছি, এসকেলেট করছি, টিবি বাড়ছে না, তো আমাদের একটা ডোবুটামিন ট্রায়াল দেব। এখন আপনারা হয়তো ইউরোপে, আপনারা আমেরিকাতে হয়তো সবসময় এটা আপনার প্র্যাকটিস দেখছেন, আপনাদের কাছে হয়তো তেমন কোনো ইট ডাজন্ট মেক এনি ডিফারেন্স। বাট সামান্য একটু যখন আমি ডোবুটামিনের ছোঁয়া দিই, কিছু পেশেন্ট থাকে ডোবুটামিন রেসপন্সিভ, এবং আমি তখন দেখা যায় ডোবুটামিন দিয়ে আমি কিন্তু এক্সিলেন্ট পেশেন্টকে বের করে আনতে পারছি। এখন আমার ওই সময় যদি ইনভেসিভ পিপি মনিটরিং না থাকে, হাউ মাই রেসিডেন্ট ক্যান জাজ whether the patient is dobutamine responsive or not? মানে আমি বারবার একটা কথাই বলছি যে স্টিক টু দ্য বেসিক, গো ফর দ্য ডায়াগনোসিস, চুজ দ্য অ্যাপ্রোপ্রিয়েট ভেসোপ্রেসর অর আয়নোট্রপ which fits for that patient. ক্রিটিক্যাল কেয়ার হচ্ছে ইন্ডিভিজুয়াল মেডিসিন, ইটস নট আ প্রোটোকল। আমরা প্রোটোকল অবশ্যই থাকবে, প্রোটোকল ইজ ফর দ্য জুনিয়র ডক্টরস এবং জেনারেল ইয়ের জন্য। বাট আমরা যখন ইন্ডিভিজুয়াল প্র্যাকটিস করছি, এই পেশেন্টের নরেপিতে ভালো কাজ করবে না ডোবুটামিনে কাজ করবে, আমি যখন দিয়ে যখন রেসপন্স দেখব তখনই বুঝবো। আর কার কত ডোজে কাজ করবে, ইট ইজ ভেরি ইন্ডিভিজুয়ালাইজ। আমার কাছে আমরা যদি দেখা যাচ্ছে যে আমি যদি পেরিফেরাল ভাস্কুলার রেজিস্ট্যান্স, যেমন হেমোস্ফিয়ার দিয়ে পেরিফেরাল ভাস্কুলার রেজিস্ট্যান্স আমরা দেখতে পাচ্ছি, দেখে যদি আমি সেটাকে টাইটেল করি, দ্যাটস এ এক্সেলেন্ট মেথড। তো মানে আমাদের কাছে কিন্তু অলরেডি বেশ কিছু টুলস আছে যেগুলো হয়তো আমরা আরো ইউজ করতে পারি। আমার কাছে আল্ট্রাসাউন্ড ইজ দ্য বেস্ট বেডসাইড টুলস, ইনএক্সপেন্সিভ, বারবার ব্যবহার করা যায়, এবং লার্নিং কার্ভ এত কম যে আমার
I
প্রত্যেকটা
think
রেসিডেন্ট
your
ইউজ
points
করতে
are
পারি।
extremely valid and very much to the point.
রাইট
Um,
রাইট
Basic
And
বাদ দিয়ে
জি জি
advanced
জি
care,
জি
technologically advanced care, the goal is not to replace it. The basic understanding and care must be there. That must be
ইয়েস
founded.
ইয়েস অফকোর্স অফকোর্স। এন্ড আমি বলবো যে এখনো বাংলাদেশ সেটআপে আমরা ইনভেসিভ মনিটরিং এর দিকে আমরা বেশি আরো জোর দিতে পারি। সো আমাকে এইখানে এত একটা ভালো ক্রাউডের সামনে কথা বলার সুযোগ দেওয়ার জন্য পিএইচএ কে ধন্যবাদ। জি, আসসালামু
No,
আলাইকুম।
thank you so very much. এই পর্যায়ে any other faculty or panelists who want to comment
I
on
want
this?
to know from the panelist or Dr. Morshed. Sometimes we are in fear that the patient is hypotensive on noradrenaline. Then we feared about to add the dobutamine. So this is a common fear in our settings. So what is your comment? The patient is getting norepinephrine at dobutamine.
So, as I think the last speaker said, so in the limited resource setting, also at that point, you can just give a trial, as because you don't have enough information, but at least with the trial of dobutamine, there is nothing to lose, as because anyway, the patient is worsening. So, and also in our setting, actually, in some places where the patient cannot be transferred or the TMCS cannot be placed, we go with the norepinephrine and then we add dobutamine and we give the trial. So even there is a fear, but on the other side, whether the fear is more worse than the benefit, I don't think so. Because if you use or don't use, either way is getting worse.
আরেকটা ব্যাপার আমি
To
অ্যাড
me,
করতে চাই এই কমেন্টের সাথে যে আপনি ডোবিউটামিন যদি আইনোট্রপ অ্যাড করেন, yeah, there is a chance because it is also a vasodilator, either it is a dobutamine or milrinone, it's a big vasodilator because of the B2 receptor activation. However, if you are increasing, but the ratio of the B, because both of them are like, especially dobutamine works B1 more than B2. So if your cardiac output is significantly going higher with the inotrope, so in that case, that can be compensated. Even the blood pressure can go higher. Not only, if it is responding, in that case, dobutamine would be the best or the milrinone would be the best option, even though there is a chance of dropping the blood pressure because ultimately the blood pressure will go up because of the increasing cardiac output.
Yeah, I would agree with that. That makes a lot of sense. And after all, dobutamine is a short-acting medication. So, one can be cautiously titrating, slowly going up and watching, the heart rate and the PVCs, or things are getting out of control or not. And if you stop it within a few minutes, it's going to be washed out of the body. And the hope is that the cardiac pump would be way out of proportion to the beta-2 induced dilatation of the vasculature. So that if the pump is better and there is some SBI drop, still the mean arterial pressure will be on target or possibly
Actually,
better
I
to
would
stop the
prefer to get the
microcirculation.
vasodilatory effect to increase the perfusion as well as the cardiac output. So if I
Exactly.
increase the cardiac output and make it vasodilated, it will increase the actually end organ perfusion more than that vasoconstrictor.
Provided the cardiac output is higher than the degree of vasodilatation and dropping SBF.
Exactly. Actually, I have a
and
few
there is
comments.
Yeah, there are some saying that the dobutamine responsive কিনা আসলে. Though if
এটাই
the
হচ্ছে
patient is
কথা।
dobutamine responsive, আমাদের আসলে এই একটা ফিয়ার ছিল যে ডোবুটামিন দিলে বিপি কমে যাবে, এরকম একটা ফিয়ার আমাদের ছিল। বাট লাস্ট ফিউ ইয়ার্স এর প্র্যাকটিসে এখন আমার রেসিডেন্টরা যদি দেখে যে রিফ্র্যাক্টরি, দে শুড গো জাস্ট অনলি অ্যাটলিস্ট ওয়ান ট্রায়াল তারা যাবে। বিকজ আমরা প্রতি 4-5টা পেশেন্টের মধ্যে হয়তো একটা পেশেন্ট ডোবুটামিন রেসপন্সিভ পেয়ে যায় এবং দ্যাট চেঞ্জেস আ লাইফ। Dobutamine response,
as long as you check that there is a myocardial contraction problem, significant
of course,
problem.
of course.
Because in the absence of that is going to be.
So actually, when
yeah.
you use dobutamine, so it's kind of difficult to say as because whether the beta-2 receptor is already down regulating or not. So we exactly don't know. In theory it is, but in practical, so that's why when we give the trial, then we know it's improving, means it's still the beta-2 is active. Because the minute we go all the way up to high dose, a lot of times the down regulation, even we give the trial, it doesn't work. So that's the soft point. So where like no trial or anything can tell is only by the
individualized patient outcome, like
individuals, right.
Each and every all the plan for treatment should be individualized according to the patient.
Right. Excellent.
I have actually few comments about prior to that. It's a very excellent presentation from Dr. Salehin and Dr. Morshed. I really learned a lot. Thank you so much for the excellent and fantastic work. But I have few comments about comment about the case that Dr. Salehin presented. Somewhere we are talking about a lot of invasive, lot of monitoring. I think those things are absent in Bangladeshi setup means it's not, we don't have that mechanical support and all this available widely. So echo would be actually the point of care ultrasound, the same thing. Dr. Rahman and Dr. Motiul, I very agreed with that. Even for this patient, even not only that, in America, the patient Dr. Salehin presented, I would prefer to get a focus or a echocardiogram right after the cath lab. So in that case, if we see that LV is aneurysmal already because it was 36 hours late presentation, So in that case, actually, there was no justification using balloon pump because it's already LV is already faked. It means it's scarred out, aneurysmal. I don't expect that only the afterload reduction will help this patient rather than doing something which will improve the LV to pump out the blood, which is impella. But in Bangladesh setup, we don't have impella. We could use the ionodrop. And especially the diagnosing the RV dysfunction for this patient was crucial as well. I saw that you have that parasternal view images. I'm sure you have the apical 4-chamber. That would help actually diagnose this RV dysfunction as soon as the patient come out of the cardiac cath lab. Like it would be very helpful if we have a really good echocardiogram. So because it's not, we don't actually, whenever we suspect or we see that RV, especially wraparound LAD, you get mid to distal RV dysfunction, not really basal, because your TAPC, all this actually measures your basal function of the RV, which is very different from the mid to distal dysfunction. And for that reason, actually, we use Simpson for the RV function. So if you first you 2D, you're visually seeing that it's not moving mid to distal, then you do the RV Simpson, you get it low. So you know that you are expecting or you are dealing along with the LV and RV dysfunction. In that case, I think that your intervention would be different, like doing the impella, like one echo would make big difference for this patient. It will prevent you to put the balloon pump, because we know that shock 2 trial didn't show any difference with the balloon. Not shock 2. That was, I think, yeah, exactly. But yeah, shock 2 shows that balloon pump no difference, but the Protect 3 showing the entire impella has a big difference with the outcome. So it would help to put the impella at the first point as soon as possible, along with starting a ionodrop, which also have the, I will prefer milrinone over the dobutamine for this case because of the RV dysfunction. So what I will prefer to choose the ionodrop, which has also pulmonary vasodilatory activity, which can reduce the afterload for the RV. So that would be, echo would make a big difference for this patient. And
Thank
which
you,
is
Dr.
helpful for
Munira,
Bangladesh as well.
Thank you so much for your extremely relevant.
লুলু ভাই
informative
আমার
presentation.
একটা আন্দাজে আমার কথা সালেহিন থেকে জানতে চাচ্ছি, সালমান থেকে, ওর পেশেন্টের আউটকামটা কি হলো শেষ পর্যন্ত? জাস্ট কিউরিয়াস, হোয়াট হ্যাপেন টু দ্য পেশেন্ট ইভেন্চুয়ালি? সালমান,
Salman, your speaker is off.
Yes, জি
Thank you.
জি আমি হচ্ছে আমার যে লাস্ট স্লাইডটা আমি রেখে দিছিলাম just for this. The patient outcome was actually good. So again, because there was a gap, আমি সবাই বলতে চাই যে it was a late presenting STEMI patient that we had inferior. First of all, we thought it was LV failure, so we started with a balloon pump, then upgraded to impella, but at the end it turned out to be a RV failure, needing something for the RV. So Tasbir, to his point, the patient actually did very well. Once I think I stopped at this slide where we had started the balloon pump, upgraded to impella, and then started him on milrinone. This is where we ended the slide, Tasbir, before we ended. And we actually stayed the course. We stayed in the CCU, and patient actually kept on doing better. The next hemodynamics, I don't have it here, but PAPI actually got back to normal, like over 1. CVP kept on improving, wedge got better, lactic started to downtrend. So আমাদের patient outcome ভালোই ছিল at the end of the day, but as everyone mentioned, there could have been some things done differently, some things that could have been done earlier on. So it was a learning point.
Excellently. ইনটিউবেশন করলে পরে ওই রোগী বাঁচানো কঠিন ছিল মনে হয় আমার। ইনটিউবেশন করার পরে তো আবার মিরাজোলাম ফেন্টানিল দিলে ওনার হাইপোটেনশন হয়ে যেত।
point taken. Plus, we would আমাদের intubate করতে সমস্যা ছিল না. It's just at that point we didn't think like the patient needed intubation. We just wanted to observe
ইন্টুবেশনে
on
হচ্ছে
how
যে
he was doing since he was
মিনিমাম
doing okay.
তোমার পিপ দিতে হতো, সেটাতেও তোমার আরবি ডিসফাংশনটা আরো বাড়তো।
G man, exactly. So anyways,
that is
from
not,
this
I
case,
mean, it can potentially happen, but that is the purpose of properly synchronizing the ventilator and the patient, making sure that the RV afterload does not go up. So in a way, you can reduce the preload, you can reduce the afterload without increasing the RV afterload and maintain synchrony, thereby reducing the work demand on the myocardium. So that, yeah, that certainly needs certain degree of skills. But by the time patient is in shock, cardiogenic shock, and we are not expecting within minutes dramatic improvement, there has to be a decision made, and certainly intubation mechanical ventilation properly done is justified.
লুলু ভাই, আমার মনে হয় ওখানে চ্যাটে দুটো কোয়েশ্চেন আছে, আমি কুইক একটু অ্যান্সার দিয়ে দিই।
Please.
So one question is about the any limitation of lactate in hepatic failure and CLD. Yes. Then we follow especially the hemodynamic numbers and CVP oxygen saturation to see hypoperfusion. We can see that, but one number. So we try not to depend only one number, but even in the limited resource setting, sometimes LVEDP is only the number. And the second question is how to differentiate heart failure CS from MI cardiogenic shock. So major thing is the EKG, not any blood work or anything, not troponin. If you see ST elevation or evolving change of the ST, so that's how we differentiate from the heart failure CS to MICS. Thank you.
সালমান তুমি শেষ করো। হ্যাঁ,
Tasbir, thank you. So anyways, it was a good learning case for me as well. আমার নতুন কিছু শিখলাম এটা থেকে। Just few take home messages for me at least was, again, as we mentioned and Dr. Morshed sir's presentation, that invasive hemodynamics is critical for STEMI patients and cardiogenic shock patients, because at least 8 to 10% of our MI patients will end up with cardiogenic shock, more so with STEMI than NSTEMI. And Bangladesh's প্রেক্ষিতে it might be difficult কারণ again, research is the limiting factor. Invasive hemodynamics is difficult to do with a swan, but Dr. Rajuddin Sarje Bullen Square, they're using something very similar for invasive hemodynamics. I think that's going to help them guide treatment. RV failure, again, we associate this with inferior STEMIs.
এकोটা একটা গুড একো হচ্ছে একটা বিশাল ফ্যাক্টর বাংলাদেশে।
Right.
গুড একোটা হবে যে
good echo, lab work, lactic, those are very important alternatives. RV failure, we associate
Salman,
this
just 1 minute, Salman. In our country, we routinely do not have swan guns. Okay, so if we want to use a millinone or levosimendan, should we do swan guns or we just rely on clinical parameters?
Clinical parameter, I mean, if we don't have an option, I think LFTs, creatinine, lactic acid,
we do
urine
use
output.
actually milrinone without swan gun or right heart cath.
Yes, one thing is that in our country, milrinone even is not that much available. Levosimendan is recently available, but we heavily rely on
pretty similar mechanism of action, levosimendan and the
If the patient wasn't beta blocker before at the time of cardiogenic shock, I guess levosimendan can be a preferred choice.
Yes. Okay,
সালমান
you can continue, Dr.
সালমান
Salman.
একটু শেষ করে নিক, তারপর উত্তর দেবে না। হ্যাঁ, তুমি শেষ করে নাও। হ্যাঁ, আদারওয়াইজ ইন্টারাপশন বেশি হচ্ছে। হ্যাঁ।
And then RV failure, again, we associate this with inferior STEMIs, again, based on the data, anywhere from 20% up to even in some literature, it's said as 50% prevalence of RV failure in inferior STEMI, although that I think the number is more close to 20-30%. But it's also a possibility in the LAD STEMI, like we found out today, the septal wall being conferently infarcted and the septum contributing 40 to 50% of the RV function, especially for patients with LAD, wraparound LAD, because then a lot of the RV blood supply is coming from the LAD. So for those cases, even though if it's a LAD STEMI, RV failure should be kept at the back of the mind. Inotropes, again, not ideal in the setting of ischemia, but can be effective if it is used in the right patient. And especially Bangladesh Precredence, since the talk today is about resource cardiogenic shock management in the research limited setting, I think inotropes has a very important role. And like Dr. Morshed sir has already touched on, the danger shock trial has changed our practice, at least in our institute, quite significantly. We do STEMI cardiogenic shock patient invariably almost always goes to the Impella CP nowadays, because again, IBP CS trial and the ECMO CS trial, IBP shock trial, those are all negative trials. So again, in this case, they had used an IBP, but I'd say most of our faculty or teams would have actually preferred the Impella from the get-go. And আমরা সবসময় বলে থাকি, there's a common saying that, lactic doesn't lie. Dr. Morshed's presentation also included how important lactic is. But if you look at our case, the lactic did lie. It wasn't super elevated, or it wasn't elevated above normal. So it, wasn't like it's not always that lactic doesn't lie, but I think it's an important factor, and it's important to trend the lactic rather than just go off all on one setting. আমার মনে হয় সবকিছু take the whole clinical picture as a whole, hemodynamics, blood work, lactic, creatinine, LFTs, and the physical exam findings, just to take everything as a whole would be the key here. That was my take-home message. Thank you very much.
Thank you, Salehin. Tasbir, you'd like to have some comments?
আসলে আমার মনে হয় চমৎকার প্রেজেন্টেশন ছিল সালমানের, চমৎকার প্রেজেন্টেশন ছিল মোর্শেদের, এত চমৎকার প্রেজেন্টেশন যে আমি অনেক কিছু শিখলাম আজকে, এবং হাউ টু প্রেজেন্ট এটা সালমান থেকে শিখলাম অনেক কিছু, যে কিভাবে অডিয়েন্সকে ধরে রাখতে হয়। প্যানেলিস্টদের পার্টিসিপেশন ছিল অসাম। তা আমি একটু বলবো যারা একদম জুনিয়র লেভেলে, বাংলাদেশে যেহেতু আমাদের টপিকস ছিল ম্যানেজমেন্ট অফ কার্ডিওজেনিক শক ইন রিসার্চ লিমিটিং সেটিং, আমি বলবো যে যেটা মতিউল বললো সেটাই আমি বলতে চাচ্ছি, যে দ্য বেসিক, যেমন আমি যখন শক দেবো, অনেক ক্ষেত্রে শকটা আমরা জানি না কিরকম, আনডিফারেন্সিয়েটেড শক। সো বেসিক্যালি ইফ ইউ লুক এট দ্য পেশেন্ট, ইফ ইউ সি পেশেন্ট ইজ জাস্ট লুক এট দ্য blood pressure. If you see the pulse pressure is narrow, think of more, cardiogenic shock. If you see the pulse pressure is wide, more distributed shock, right? আমরা যদি দেখি যে JVP high, আমরা যদি দেখি যে patient a lot of crackles, most likely cardiogenic shock, right? তারপর যেটা আমাকে বললো মোর্শেদ বললো, shock index, such a small simple thing, যে heart rate divided by systolic blood pressure যদি more than 0.7 হয়, তাহলে পেশেন্ট শকে যাচ্ছে, আর more than 1.4 হলে তো শকই, সিভিয়ার শক। তারপর ডায়াস্টলিক শক ইন্ডেক্স, তারপর যদি আমরা প্রপোর্শনাল পালস প্রেশার, যেটা একদম ইজি, পালস প্রেশার ডিভাইড বাই সিস্টলিক ব্লাড প্রেশার, সেটা যদি দেখি বিলো 25%, নর্মাল হচ্ছে 25 to 40%, তার মানে পালস প্রেশার ডিভাইড বাই সিস্টলিক ব্লাড প্রেশার টাইমস 100, যদি ফলস বিলো 25%, উই নো পেশেন্ট কার্ডিয়াক ইন্ডেক্স ইজ বিলো 2.2। সিম্পল যে মেজার্স, তারপর পেশেন্ট কি কোল্ড ক্ল্যামি নাকি মোর ওয়ার্ম, তার মানে ওয়ার্ম হচ্ছে ডিস্ট্রিবিউটিভ, যদি কোল্ড ক্ল্যামি হয় মোর সার্কুলেটরি শক। তা আমরা যদি এই বেসিকগুলি, তারপর যদি আমরা একোটা, যেটা বারবার এমফাসিস দেওয়া হচ্ছে, যে যদি উই পুট দ্য প্রব, look at the heart, look at the IVC, look for the B lines, look for the lung sliding, look for the free fluid in the stomach, in the abdomen, তাহলে কিন্তু আমরা মোটামুটি বুঝে যাচ্ছি আসলে what kind of shock we are dealing with। এবং সেভাবে আমরা অ্যাটলিস্ট আইনোট্রোপ, তারপর হচ্ছে যেটা মনিরা বলছিল সবাই, যে আমরা ডোবুটামিন দিলে মনে করে ব্লাড প্রেশার ড্রপ করে, আসলেই ড্রপ করে, আমার এক্সপিরিয়েন্সে বলে যে ড্রপ করে। তো ইনিশিয়ালি হয়তো বা আমাদের ভেসোপ্রেসার দিতে হবে নরএড্রিনালিনের সাথে dobutamine বা Milran, then we can take off the norepinephrine when the heart start kicking and get the cardiac output better. তো সেটা এই জিনিসটা দেখা উচিত আমার মনে হয় আইনোট্রপ দিয়ে। আর আমি একটা জিনিস ভাল লাগলো না, আলামিন বলছিল পিএ ক্যাথেটার তো আমরা দিতে পারি না। তোমরা যদি বাইপাস সার্জারি করতে পারো, তোমরা যদি স্টেন্ট দিতে পারো, তোমরা যদি বেলুন পাম্প দিতে পারো, পিএ ক্যাথেটার কেন আনতে পারবে না? ইটস এ সিম্পল সেন্ট্রাল লাইন, ইটস বিগার সেন্ট্রাল লাইন জাস্ট গোয়িং টু দ্য পিএ ক্যাথেটার। আমরা নিজেরা তো, আমার মনে হয় এই জিনিসটার উপর তোমরা যদি একটু টেক দ্য লিড, এবং পিএইচই অবশ্যই তোমাদেরকে হেল্প করবে টু গেট ট্রেন, ইম্পেলার ডিভাইসও কিভাবে দিতে হয় সেটাও আমরা হেল্প করতে পারি তোমাদেরকে। আমাদের অনেক আছে বাংলাদেশে যারা হচ্ছে বাংলাদেশি নন রেসিডেন্ট ফিজিশিয়ান প্র্যাকটিসিং আউট অ্যাব্রড, তারা কিন্তু বাংলাদেশে যে কাজ করতে চায় তোমাদেরকে হেল্প করতে চায়। PA catheter is nothing we do at the bedside. Even you don't need a fluoroscopy to put the, unless it's very difficult situation. So আমার মনে হয় এই জিনিসটা তোমরা প্র্যাকটিস করো, কেন if you don't know the number, you don't know what you're treating, whether the drug is working or not working. So আমার মনে হয় PA catheterটা তোমরা শুরু করো, at least বড় সেন্টারগুলি BMU, NICVD, ঢাকা মেডিকেল, এগুলিতে থাকা উচিত at least. এই তো, খুব ভালো লাগলো। থ্যাংক ইউ সো মাচ লুলু ভাই, থ্যাংক ইউ সো মাচ ফর হ্যাভিং মি।
তাজবীর, থ্যাংক ইউ সো ভেরি মাচ। এরপরে আর আমি আর বেশি কিছু কমেন্ট করার কিছু নাই। I think what I personally learned is early diagnosis is very, very crucial, and appropriate intervention. And whatever resources we have in Bangladesh, bedside focus and echocardiogram and a very good clinical evaluations along with bunch of indexes, which does be shared and summarized at the end, still we can do much, much better in taking care of these critically ill patients.
Thank you.
Thank you,
sir.
Lulu Bhai, for excellent moderation
you.
as well.
Thank you so very much for the brilliant contribution and making it a rich conference. And we look forward to meeting in another session, inshallah. Thank you all for your contribution.
Thank you, Lulu bhai. Thank you, Tasbir, and thank you.
খোদা
everyone.
হাফেজ, খোদা হাফেজ, খুব ভালো লাগলো, চমৎকার
খোদা
চমৎকার
হাফেজ।
প্রেজেন্টেশন ছিল। থ্যাংক ইউ।
আসসালামু আলাইকুম
Thanks.
সবাইকে।
Thank you, Tasbir bhai.
খুব ভালো হয়েছে।
থ্যাংক ইউ মোমেন, ভালো থাকো। তোমরা পিএ ক্যাথেটার শুরু করো। I think it should be
Yeah,
easy.
it is a very simple.
Just like a central
স্যার
line.
আমরা
and
তো
it's just
করতেই
bigger
চাই
catheter.
স্যার, কিন্তু উই আর ভেরি শর্ট অফ লজিস্টিক্স।
করে
we are
শুরু
quite
I
করো
used to put
তারপর।
3 for Swanganj every night during my fellowship.
স্যার
লুলু
আমি
ভাই, মোমেন
Every-
কিন্তু খুব
পিএইচডি ট্রেনিং
একাডেমিক।
করে আসার পরে
Yeah, that দেখতে পাচ্ছি।
মানে সোয়ানগঞ্জ করার জন্য আমি সবাইকে বললাম যে আমাদের সোয়ানগঞ্জ দরকার, সোয়ানগঞ্জ দরকার। ইভেন আই কুডন্ট, মানে কাউকে আই ক্যান কনভিন্স, আমি কাউকে কনভিন্স করতে পারলাম না।
Now to start with, that's a very simple technique, and with খুব fancy যে costly resource তাও নয়. I think we should add that in addition to echocardiogram and focus on clinical evaluation.
এক্স্যাক্টলি। পিএ ক্যাথেটার তোমরা শুরু করো, ফোকাসটাকে একটু বেশি ওয়াইডলি ইউজ করার চেষ্টা করো। দেখবা যে অনেক কিছু তোমার আর্লি ডায়াগনোসিস করতে পারছো, আর্লি ইন্টারভেনশন করতে পারছো। ঠিক
Thank
আছে,
you.
ওকে, ভালো থাকো
ঠিক
আলামিন।
আছে, সবাইকে
Yes,
সবাই
sir.
ভালো
Thank
থাকো।
you, sir.
সালমান
It was a
ভালো
great
থাকো।
session, sir. It was a very great.
Thank you
Tasbir
so
sir,
much.
finishing
Thank
was
you.
quite excellent.
Had
আমার
a great
খুবই ভালো লেগেছে।
presentation.
মানে এটাই আমাদের ডেইলি প্র্যাকটিসের একটা পার্ট হওয়া উচিত, যতটুকু বেডসাইড কথা
এটা
বললেন
হচ্ছে কি
তাসবির স্যার।
ডেইলি ফোকাস, মানে প্রত্যেকদিন রাউন্ডের সময় একবার প্রোবটা দিলে অনেক কিছু নতুন ডায়াগনোসিস
Focus
আসে।
এখন আইসিইউতে আমাদের স্টেথোস্কোপ হয়ে গেছে।
ফলোআপের জন্য
I'm
খুবই
focusing
ভালো।
on everybody.
আমি
এই যে
স্যার
আলামিন,
কথা বলে একটু
আলামিন তুমি
শেষ
দেখো,
করতে চাই।
তুমি যদি প্রোবটা বসাও, যদি দেখো লেফট ভেন্ট্রিকল মুভ করতেছে না, হয়ে গেল কার্ডিওজেনিক শক। ইফ তুমি দেখো বিগ পেরিকার্ডিয়াল effusion, even you don't identify that diastolic collapse, big pericardial effusion, think of tamponade.
জি
If
স্যার,
the
জি স্যার,
right ventricle doesn't move, think of right ventricular failure or PE, whatever.
The
And then if you
mechanical
see the IVC's collapse,
calculation.
বাংলাদেশে কি
IVC's
ক্যাথেটার
collapse.
ডিরেক্টেড থেরাপি আছে মাসিভ পাম্পার এম্বোলিজমের জন্য?
No, sir.
Sir,
No catheter
না
based
স্যার, না স্যার।
No catheter
ইকোটা
pump আছে।
আমরা স্যার ইউজ করি, আমরা ভালোভাবে ইকোটা ইউজ করি এবং অ্যাসেসমেন্টটা
না,
করতে
তোমরা
পারি।
জুনিয়রদের না, তোমরা সিনিয়র তো আসছেই, যারা জুনিয়র লেভেলে তাদেরকে একটু শিখায়ও। কারণ হচ্ছে তোমরা তো ধরো অনেক ক্যাথ ল্যাবে বসে আসছো ধরো, হ্যাঁ, তো জুনিয়ররা প্রথম রিসিভ করে। ইফ দে পুট দ্য প্রোব, তাহলে কিন্তু অনেক কিছু বের করে ফেলতে পারবে, বুঝছো?
তাসবির ভাই, একটু ছোট ছোট তো ওই যে ইয়ের মধ্যে ট্যাবের মধ্যেই এখন প্রোব দিয়ে পাওয়া যায়। আমাদের রাউন্ডে আমি দেখি
we have the
রেসিডেন্টরা হাতে
handheld
নিয়ে
echo.
ঘুরে রাউন্ডে।
হ্যাঁ, বাটারফ্লাই আছে,
Butterfly.
তারপর হচ্ছে
We have the
ক্যারিয়াস
handheld
আছে।
echo in our
It's about
NICD.
মোমেন
$4,000,
স্যার
I
জানেন
think.
স্যার, মোমেন স্যার আছেন এনআইসিবিডিতে ইকো করার, মানে ইমার্জেন্সি পেশেন্ট আসে ইকো করার আগে অনেক পালমোনারি এম্বোলিজম পেশেন্ট নন স্টেমা হিসেবে ট্রিটেড হয়, এটা আমরা দেখছি আর কি।
এক্স্যাক্টলি।
তোমার রাইট হার্ট ক্যাথ কিন্তু হচ্ছে অনেক সময় তোমার প্রি ক্যাপিলারি প্রেসার ফসলিলও দিতে পারে, ডিপেন্ডিং অন দ্য পেশেন্ট হেমোডাইনামিক স্ট্যাটাস লাইক ডিহাইড্রেশন অ্যান্ড অল। echo will be like based on those kind of situations.
না ইভেন দ্য ক্লিনিক্যাল বুঝছো মনিরা, এই যে পালস প্রেশারটা একটু দেখা,
Ultimately তো ক্লিনিক্যাল তাসবির ভাই।
না না তোমার এমনি দেখো সিম্পল মানে লো সেটিং এর কথা বলছে, ওদের তো ধরো একো ধরো ফোকাস নাই, থার্ড ফ্লোরে ধরো ফোকাসটা শুধু করে হয়তো বা আইসিইউ তে, কিন্তু ওরা যদি একটু পালস প্রেশারটা দেখে, ওরা যদি একটু প্রপোর্শনাল পালস প্রেশারটা দেখে, এগুলি যদি দেখে ছোট্ট ছোট্ট জিনিস, শক ইন্ডেক্সটা যদি দেখে, তাহলে কিন্তু অনেক কিছু, তারপর একটু জেভিপি রেস কিনা, ক্র্যাকেলস আছে কিনা, অনেক কিছু বের করে হতে পারবে। এক্স্যাক্টলি সেই যাই হোক,
লিমিটেড রিসোর্স আমার মনে হয় না যে এটা ডিফিকাল্ট তারপরেও, কারণ হচ্ছে এখানে
আমরা ম্যাডাম ডায়াগনোসিসে আমার মনে হয় আমরা করতে পারি, কিন্তু আমরা থেরাপিউটিক্সে যে মনিটরিং এ যে তারপরে ড্রাগ গুলো টাইট্রেশনে we actually have difficulties.
Another barrier is the pressure of patient number. So
exactly.
That is
so big in number,
discussion.
we have to concentrate simultaneously 4 patients. How do we concentrate a cardiogenic shock patient management and everything? So this is very tough job.
এক্স্যাক্টলি সেই জন্য তোমাদের জুনিয়রদের জানাইতে হবে, তুমি একা পারবা না। মেডিকেল অফিসার যদি ভুল করে তুমিও ভুল করবা, বুঝছো? ডেলিগেট করাটা খুব ইম্পর্টেন্ট। আমরা ডেলিগেশন করি না বাংলাদেশে।
টিম ম্যানেজমেন্ট,
টিম অ্যাপ্রোচ এন্ড নার্সিং ইমপ্রুভ করতে হবে,
একটা বিশাল পার্ট এখানে
নার্সিং ইমপ্রুভ করতে হবে।
অ্যাবসলিউটলি।
ওকে, খোদা হাফেজ। হ্যাঁ, অনেক
আছে,
Session was brilliant.
Thank you.
Session was brilliant.
আসসালামু
Thank
We
you,
learned a
thank
lot.
you everybody.
হ্যাঁ, আসলে খুবই ভালো
Thank you.
প্রেজেন্টেশন দিচ্ছে।
অনেক কিছু